Okay, hello everyone. Good evening from London. Good afternoon if you're in other parts of the world. It's a real pleasure to be here today and welcome you all to this ISHLT Pulmonology Council webinar. I am Anna Reid. I'm a lung transplant physician from Harefield Hospital in London. It's my pleasure to introduce the panel. So we've got an international panel with experts from across the world of transplantation and cystic fibrosis. And we thought it would be a really good opportunity to have a discussion about the dramatic change that the CFTR, the CFTR modulators have had on patients with cystic fibrosis and on the face of transplant, because it really has had a miraculous impact worldwide. So our first speaker, Professor Nick Simmonds, is from the Brompton Hospital. We've worked together a long time, and I will hand over to you, Nick, but thanks very much for joining us today and giving us your perspective from the cystic fibrosis end.
Great, thanks so much, Anna. Thank you. Hello, everyone. Thanks to the Society for this opportunity. I have to say it's great to actually be part of this kind of webinar, talking about it from the transplant end, me as a CF physician. So yeah, my title is about the dramatic impact that modulators have had on outcomes in transplant, but specifically looking at registries and asking the question, what have we learned from registries? So, I mean, in essence, I could probably summarize the history of CF in this one slide. It was originally described in 1938. It was a fatal disease. Most people, greater than 90% of people, died in the first year of life. And along the way, all these great, very important discoveries with introduction of interventions have made a huge difference. And this is the red line for median predicted survival with the modulators here. But you can see there's still investigative therapies and there's still need for more. But with modulators, we are talking about, in many countries of the world, not all countries, but many, potentially treating up to 90% of the CF population based on genotype. So dramatic changes, but also what I'd like to say, and I hope you'll get from the end of this, is there's still some work to be done. Now, why talk about registries? Well, I think it's really key to our understanding of cystic fibrosis outcomes over many decades now. It's really helped us understand the natural evolution of CF, but also some of the important things we've introduced to care. And registries really have been paramount. And I would say CF has been an excellent exemplar. So we've got a number of really important, robust registries. So this is the US CF Foundation patient registry of about 33,000 people. There's the UK CF Trust registry of about 11,000 people. And across Europe, the European CF Society registry, we have 55,000 patients who are registered. And we've learned a lot in terms of excellent research studies to better understand outcomes and interventions through these. And actually, it all started many, many years ago. And actually, one of the most important things that ever happened in CF was the introduction of better nutrition. And that was based on important registry data from North America all these years ago. So better nutrition, better survival. But even before modulators, we've known the impact that we've had from multifaceted, multidisciplinary team care to outcomes in CF. So this is a paper that we produced at the Brompton many years ago of patients with an FEV1 less than 30% predicted, showing the significant improvement of survival at that cutoff rate up to about 5.3 years. So this was pre-modulators. And my co-speaker tonight, Kathy Ramos, also using US registry data, showed that actually that was probably even greater in the US at about 6.5 years. So using these data sets, it's informed us at the severe end of the spectrum. But the bar in terms of modulators was set extremely high by the introduction of ivacaftor over 13 years ago now. So just to remind you, ivacaftor is single agent modulator. It was the first in class, and it treated a small number of people with CF based on rare mutations. But this is what set the standard. As you can see, this very robust increase in FEV1 within 2 weeks of treatment. And this was supported by this fantastic sort of novel idea of the sweat test, which is a biomarker improving, but essentially telling us it's treating the basic defect. But perhaps what's more important on a patient level was these endpoints in terms of exacerbations coming down, weight improvement. So it really set the bar. But actually, that was only about 5% of patients, and it took a number of years to investigate further products until we got to triple therapy. And triple therapy, which I'll refer to throughout the rest of the presentation, ETI is elexacaftor, tezacaftor, ivacaftor. And the reason it took a while to get to this point is because it's all based on the basic defect and the different type of mutations and what you have to do to correct it. But with triple therapy, what we realized, and this is the pivotal phase 3 study, that actually all you need is one copy of the common delta F 508 mutation, and you get a very robust response. So this is placebo, this is treatment blue, and you see a huge increase in absolute percent predicted FEV1 with the concurrent drop in sweat chloride value, telling us it's treating the basic defect. But again, perhaps what's more important on a patient, a healthcare delivery, and a transplant level is this very significant drop in pulmonary exacerbation frequency from these phase 3 trials. And actually, that is exactly what we've seen in the real world, in the clinic, and on our wards. And alongside this, they also studied patients homozygous, showing a very similar result. So actually, about 90% of patients carry at least one copy of delta F508, and these were the sort of results that we saw. And these have translated into clinical real-world benefits that we're seeing in the clinic. So let me just show you some of the current median predicted survival based on registry data, but also some really interesting work that's been done projecting the future. And I think that's really important when we're trying to understand what the characteristics, the severity of disease is going to look like moving forward, but also what's that going to mean for transplant and transplant services from a CF perspective. Left-hand side is UK registry data, and you can see median predicted survival, that's the yellow for all patients, steadily improving. And this, of course, predates modulators for the reason that I've said, but this is where the introduction of modulators started. So in the UK, it's about 56.1 years, in the US, 56.6. What this US paper here has done, using again registry data to model, project forward what potentially we'll see in terms of the breakdown, the distribution of patients in terms of adults versus pediatrics moving forward. So this is a predictive model to 2040 from looking back in 2000 to here, the current time, whereby about 70% of the population will be categorized as adults versus about 30% pediatrics. And we did something similar in the UK. This was the UK using UK registry. And conservatively, we estimated an increase of between 28 to 38% adults based on the mortality and the predicted potential improvement in mortality rates. But I always caveat these data with this. So the current median age of death in 2022 in the UK for people with CF was 33, in the US 36. So there is still a high risk population. Of course there is, because there are adults that have got established disease who have still horrible, nasty chronic infections and are dying young that absolutely will continue to need transplant. So there is this significant population that are still obviously at risk of premature death. That will slowly improve over the years, but I still think that's going to take a long time for that to happen. And this basically gives you a little bit more insights into this. So this is, again, using the US patient registry data, projecting the breakdown of lung function severity based on FEV1 from 2020 up to 2040. And the light blue and dark blue is either normal lung function and mildly impaired lung function, versus severely affected or moderately affected as the yellow and the purple. On the top, it's pediatric data. On the bottom, it's adult data. And you see straight away, there's a lot more blue predicted in 2040, not surprisingly. But there is obvious differences between the adults and the pediatric populations for obvious reasons, because the adults have developed disease already. So particularly relevant for this webinar is over, so this is 29% are still predicted to have either moderately impaired or severely impaired FEV1 by 2040. So what of these patients with low lung function? What do we know in terms of improvements? Can these modulators still work even at the potential transplant at risk range? So this is not registry data, I will add. This is data from a very small cohort of patients, but this was the first insights that we got from the introduction of triple therapy in people with very low lung function. So this shows, similar to the phase 3 studies, significant improvements in FEV1 and significant reductions in pulmonary exacerbations, even for patients with severe disease. But perhaps what's even more relevant is this really nice piece of work from France. So this is a prospective observational study. Effectively, it's a registry study in France, where they very nicely, systematically collected data on the introduction of triple therapy for those patients with severe lung disease. So less than 40% FEV1. So yes, they did gain an FEV1 increase of about 15%. And from initiation, you can see steady reductions of the association of long-term oxygen usage, NIV, and also in France, the reduction of lung transplants around this time, so 2018 to 2020, was 56.5%. The only thing I'll add is you have to be a little bit wary of the interpretation because it also crossed the COVID time, but really telling you a profound impact. And significant reduction, but still some patients requiring transplants, albeit at a much lower level. And I'm sure that's probably what you're seeing in your own centres as well. So just the final part of the talk is just giving you some more data on what we know from registries and the true impact of these important endpoints. Because you can never do a randomized controlled trial in a lifelong disease of endpoints such as death and organ transplantation. So this is probably one of the most important earlier registry studies. So UK data, US data on the left, UK on the right. And this, though, just to add, is ivacaftor, so single agent. And they very nicely showed, though, with a comparator group, so non-treated group, the reduction in risk of death across both cohorts, as you can see there, of 59 and 48%, and the reduction in the risk of transplant of 85 and 44% between the different countries based on registry. So what of the future? Can we predict the future? Well, I've already showed you some prediction models, but I will also caveat, as I've already said, that we know certainly in the UK registry, there are still significant numbers of patients with low lung function that they may well have stabilized with modulators, but this is still going to drive disease because they still have chronic infections and they have established bronchiectasis. But this study is tantalizing this is an open label extension of the triple therapy data, which shows that over a 2-year period, compared to a registry matched control group who weren't treated, potentially, remember this is in a study population, that they really can reduce the rate of decline for the very long term. So starting patients very early may well have the most dramatic impact in the long term. But that's not to say that those with established disease are not going to still require these sort of more traditional interventions. But this is a really interesting, albeit still only 2 years worth of data study. And then my final piece of data before I finish is this, which I think is really intriguing in terms of trying to model data. So this is from the Canadian registry. And what they did is they used a really neat piece of methodology, which is a microsimulation study. And what they've basically done with their registry is they've simulated 3 scenarios of patients based on a baseline of 2018. A group of patients, so the patients who modelled didn't start triple therapy, those that started it early in 2021, and those that started it late, which they've called delayed at 2025. And they've forecast looking forward to 2030 certain scenarios and certain outcomes in terms of severity of lung function, death and transplantation. And this is a nice, neat way of showing this. So this is the baseline group, and this is going all the way for 10 years worth of data. And the distribution, if they didn't start modulators as the A, or if they started modulator, i.e. triple therapy, as the B, as the early starters. And you can see the distribution of mild disease versus severe disease and moderate disease is very different. And there is a significant difference in survival. But this is probably the most important from this perspective, from a transplant perspective. So you can see a really considerable difference in the number of transplants from starting triple therapy straight away in patients, or a delay. What a delay of just a few years might mean for services in different countries if you do or don't have it, or if you're only able to prescribe it for a certain number of patients. These data, I suggest you have a look further at this paper because it's very intriguing, as you can see, in terms of the reduction from potentially 146 fewer transplants to 98 fewer transplants, dependent on the introduction in your services. So I'm going to finish. Yes, without doubt, modulators are very effective and they have been transformative. They are absolutely improving outcomes, but remember, CF is a spectrum, and therefore it depends when you start the drug. transplant rates are down, but there's absolutely still a cohort that need them. There's also, of course, the cohort that I haven't talked about that are currently not eligible or intolerant, or whereby the drug is less responsive. So, you know, CF is changing, lung transplant demands are changing, but I do still think it's going to be an important treatment option for the foreseeable future. So with that, I'll say thank you and hand you back to Professor Reid. Thank you very much.
Thank you. That was great talk. Lots to think about in that, and I agree, you know, landscape is changing, but we still will be transplanting CF patients. We should probably leave questions to the end. So if you have any questions that you want to put in the chat, please go ahead. We'll try and keep some time for questions for all of our speakers today, right at the end. I think there's a lot to talk about. So I'd like to introduce next Asbjørn Lunnan from Oslo. Asbjørn is a pharmacist, and he's going to talk to us about the medications, side effects and interactions, which obviously in a transplant cohort is very important. So thank you very much for joining us today.
Oh, thank you. Okay, so I'm going to cover the pharmacist part of this. So let's start with how they work. And to understand how they work, we need to understand what CF protein is, the cystic fibrosis transplant conductance regulator. This is an ion channel consisting of 1,480 amino acids. It's encoded by the CF gene. And in the novel Anna Karenina, Leah Tolstoy writes, all happy families are alike, and each unhappy family is unhappy in its own way. The CF gene is a bit like this. There's one conformation that's correct, and there's about 1,700 different mutations you can have that leads to a defect that's currently known. If you have a defect, it means that the protein, it can mean various things. There are different classes of CF, and we can address some of them with drug therapy. Some mutations, including the FR8 delta, which is the most common one, causes a mishap in the protein folding, which means that the protein can't reach the surface of the cell properly, and then it can't do its actions. And the lumacaftor, elexacaftor, and tezacaftor drugs, they work by stabilizing this. They're a bit like a crutch for the protein, so it gets there. Then we have ivacaftor, and this one works by keeping the channel open, so it improves conductance. If you're interested in the mechanism and the science behind it, I'd really like to recommend this presentation here, No Mutation Left Behind, by Joseph Plewski. It's on the ISHLT YouTube channel, so it goes really in depth there. So let's talk about the drugs. There's currently 4 drugs on the market that we can use. The first one was ivacaftor. And then they just keep piling on different substances. And currently, the state-of-the-art treatment is this triple therapy, ETI, which is named Trikafta in the US and Kaftrio. I'm going to focus the rest of this talk on this because this is what we're currently using the most. Let's look at the pharmacokinetics. So first of all, the absorption of these drugs is quite variable. And the variation is based on whether the drugs are taken with fatty foods or not. So the manufacturer recommends that all of these drugs are taken with a fatty food, both ivacaftor and ETI. Then we have volume of distribution and half-life. The most significant thing here is that ivacaftor has a significantly different half-life and volume distribution compared to tezacaftor and elexacaftor. And this has an impact on dosing. We need to dose ivacaftor a lot more often, but twice as often, in fact, in order to keep it at a steady level. Then there's metabolism. This is metabolized in the liver, all 3 of them, by the enzyme CYP3A. That's important in regard of drug interactions, and it's excreted in the feces. So the good thing about this is that it's not excreted by the kidneys. So we don't need to think about kidney function. We do, however, need to think about liver function. So what's a typical dosing scheme? This is what the manufacturer states. For adults, you take 2 ETI tablets in the morning and 1 ivacaftor in the evening. And for children, that's of less than 30 kilograms, you give half that. That's the typical like baseline regimen. So let's discuss side effects. And this table is taken from the phase 3 trial of Trikafta. And as you can see, these are patients who already experienced a lot of adverse events. But what was different in the treatment arm was that they experienced a bit more headache and a bit more GI issues. And moreover, it's also said in the text that rash was common, particularly in women who were on hormonal contraception. And there were some adverse events with elevated aminotransferase levels, so liver enzymes might increase. There's also been post-marketing reports of liver failure on these drugs. But all in all, the side effect profile is mild, and that's a good thing. The liver is also important here in terms of hepatic impairment. How do you dose it then? And if it's mild, it's easy, you don't do anything. If it's severe, there's no data, so I guess you have to make an educated shot in the dark if you really mean that the patient should have these drugs. But for the moderate class, there are concrete dosing recommendations. And you get this scheme. You take two ETI tablets on day 1 and 1 ETI in tablets on the day 2. So you get this, it's a reduced dose, you give a lot less. And that's important to keep in mind if your patient has hepatic impairment. If you go over to drug interactions, these are drugs that will interact with medicines that affect CYP3A. And if the patient is on a moderate CYP3A inhibitor, we also need to reduce the dose. We need to cut it by half. So first day we take 2 tablets of ETI. On the second day it's 1 tablet of ivacaftor. So this is about a 50% reduction. Typical drugs in CYP3A inhibitor class are fluconazole, erythromycin, and verapamil. And with the strong CYP3A inhibitors, we reduce it even more. You just take Trikafta 2 times a week. And this is interesting for 2 reasons. First of all, these are drugs that are typically used by lung transplant patients. So if we are introducing modulator therapy in patients who already got a transplant, then we need to adjust the dose of Trikafta as well in order to avoid interactions if they are on antifungals. And the second thing that's interesting is that these are drugs of an exorbitant cost. So I'm sure we will see protocols around the world in places with limited resources where they will try to save tablets by also co-administering some CYP3A inhibitors. I'm pretty sure we will see data on that. Let's see. So the other side of the CYP3A coin is the CYP3A inducers. And here we find drugs like rifampin. There's one case report on where they have tried to give rifampin therapy to a patient on ivacaftor, and what they experienced was that the patient had a clinical deterioration while on the therapy, and this is logical. And we will probably see this on ETI as well. So if the patient needs rifampin or anything else, we need to manage that. Finally, there are also some drug interaction with immunosuppression, and that's because ETI works as a P-glycoprotein inhibitor, which is involved in the pharmacokinetics of the CNIs, tacrolimus and cyclosporin. And this will roughly lead to an increase in troughs of CNIs. There's a case series in the Journal of Heart and Lung that has looked at this. I think it was about 9 patients, and they found that most patients required a tacrolimus dose reduction after starting on ETI. It was not very much, it was about 20%. So you need to keep it in mind, but it's certainly manageable. So to sum all of this up, the CFTR modulators, they work by correcting defects in the CFTR protein. So we can only have therapy where it only works for the known defects that actually can be addressed by these drugs. Side effects are generally mild, and there are significant drug interactions. So if you're going to give these drugs to your transplant patients, you need to, or anyone else really, you need to keep this in mind. That's it.
Thank you very much, Asbjørn. I think it's very interesting thinking particularly about the interactions. Is it, I feel like I should know this, but I don't, is it possible to do therapeutic drug monitoring for the modulator therapies?
Not that I'm aware of.
You've appeared, so maybe you can answer my question.
Yes, I can tell you that it's very much a research area right now. Jennifer Gimbalot, who was at University of Alabama, just moved to University of Arkansas, was doing this as a research protocol and has published data related to that. But National Jewish in the United States, in Denver, just developed a clinical test that they're allowing people to send samples commercially. But what to do with the results of that is completely unclear. So it's very helpful if you have a 0 level, because their patient may not be taking it or is completely not absorbing it. But what to do with the numbers is very difficult to know.
Okay, because there's no normal ranges. Okay, fine.
Yeah.
Okay, thank you. Thanks, Asbjørn. Shall we, so our next speaker is going to talk to us about a patient who was taking CFTR after the lung transplant. So it's a pleasure to introduce Usman Katawa. Usman is a lung transplant physician working in Cambridge, so not too far from here, and is an early careers ISHLT member. So we're absolutely delighted to have you join us today, and really pleased that you've agreed to present and become more involved in the society. So welcome.
Thank you so much, Anna. That was quite generous of you. So I'll start off with my case report. So my name, as I said, my name is Usman. I'm one of the lung transplant registrars currently working at Papworth, and we'll be highlighting a case study which depicts potential pitfalls in patients using CFTR post lung transplant. So we present the case of a 30-year-old gentleman who had a bilateral lung transplant for cystic fibrosis. So this gentleman was diagnosed at the age of 8 in his home country, which was Eastern Europe. We moved to the UK in 2020, had a history of recurrent chest infections, chronic diarrhea, failure to thrive, elevated fecal calprotectin. Lung function-wise, his FEV1 at the lowest was around 13% predicted. He also had compensated type 2 respiratory failure requiring nocturnal and BiPAP, and had exertional desaturations down to 79%. Apart from that, as shown here, he had CF-related diabetes, CF-related sinus disease, gastroesophageal reflux disease, fatty changes on his liver imaging, previous DOS with possible colitis, and chronic colonization with multi-resistant Pseudomonas aeruginosa. 24 months post-lung transplant, a multidisciplinary decision to start a CFTR was taken, which was done involving the CF team. This was in view of his sinus disease, poor diabetes control, and digestive tract symptoms. One point of complexity was the interaction of CFTR with all of the transplant medications, as very adequately mentioned in the previous slide, and to sort of see how to manage these interactions in a real world scenario. So basically, on one hand, antifungal azoles are inhibitors of CYP3A4, 2C9 and 2C19, and are responsible for an increase in tacrolimus levels. On the other hand, lumacaftor and ivacaftor are strong inducers of CYP3A4 and are therefore decreased blood levels of substrates of this enzyme such as voriconazole and posaconazole. We admitted our gentleman for 14 days to commence CFTR under supervision. There was a stepwise dose increase of CFTR with strict clinical, biochemical, and therapeutic drug monitoring. He was started on 1 pill a day for 5 days. We moved on to 1 pill twice a day until reaching the final dose of 2 pills twice a day at day 14, with 1 ivacaftor dose of 150 milligrams to be taken in the evening. Apologies for this. In a meeting, please. Thank you. Now, there were no immediate adverse events reported. His liver function tests remained within normal range, and clinical tolerance was good. There was 50% reduction in the tacrolimus requirement. We discharged him and followed him up in clinic at around 6 weeks interval. Unfortunately, at this point of time, he reported abdominal distension, loss of appetite, nausea, and vomiting. Examination confirmed a 3 finger breadth hepatomegaly, which was also confirmed on imaging of his liver ultrasound. He had deranged liver function tests, and when we went looking, he had a negative hepatitis virology, including hepatitis E. Now, this graph represents the track of his liver enzymes. He was commenced on CFTR around 6th of September, early September. and his levels peaked around the 6-month mark towards mid-October to the late November period. That was when his CFTR was stopped, and since then the liver function test started to stabilize and plateau within the normal ranges. In case of so what to do in case the liver function enzymes are elevated? If the aminotransferases are about more than 5 times the upper limit of normal without rise in bilirubin levels, or if the liver ALTs are aminotransferases are more than 3 times the upper limit of normal, with about 2 times the bilirubin rise of about 2 times the upper limit of normal, the advice is to interrupt treatment dosing and monitor the liver function until they are within a normal limit. And following resolution of the liver function tests to the normal limits, the advice is to strongly reconsider the risk versus benefit comparison of resuming treatment. Now, this is just to show that we did an ultrasound liver, which confirmed that the liver was enlarged. However, there were no structural problems ongoing. He, apart from hepatomegaly, the portal vein flow was dampened, but it was still hepatopedal direction. There were no evidence of ascites and spleen measures within the upper limit of normal. We spoke to our friendly local hepatologist who fortunately had seen the patient before and for CF-related liver disease, and essentially to rule out any other causes of his liver dysfunction, and and look for the causes of hepatomegaly such as veno-occlusive disease or Budd-Chiari syndrome. However, he was fairly convinced that the culprit at this point of time was the medication, or it was a drug-induced liver injury. Now, obviously, so cystic fibrosis can lead to liver fibrosis on its own and cause liver cirrhosis on its own, and elevations in ALT and AST are common. However, these have been observed. They have also been observed in patients treated with CFTR-deco combination therapy. So regular monitoring of liver function, including transaminases, has been advised since authorization. It is not possible to estimate the frequency of reports of serious liver injury or bilirubin elevations, and the mechanism of liver injury at present still remains unknown. Ivacaftor, tezacaftor, and elexacaftor are metabolized by the CYP enzyme, CYP3A4. Tezacaftor is glucouronidated. All 3 compounds are highly protein bound, primarily to albumin. So in case of impaired albumin synthesis, the drug concentrations can potentially be higher, which could lead to more adverse effects. Elexacaftor and tezacaftor are metabolized by biliary excretion. So potentially in cases of liver disease, they can also tend to be accumulated in advanced liver diseases. Now, in the UK, we have the yellow card reporting systems, and from October 2020 and up to the 12th December 21, the yellow card scheme received about 22 reports of serious liver disorders and 54 reports of abnormal liver test results. 6 of them had concomitant bilirubin elevation. All of these associated with CFTR-deco combination therapy. As for all medications, the MHRA will keep reports of suspected serious adverse drug reactions under their close review. In the USA also, the disproportionality analysis were conducted on FDA adverse event reporting system data from the 4th quarter of 2019 through to the 3rd quarter of 22. And basically the one of the studies show that the hospitalization was the 2nd most common patient outcome for CFTR-associated liver disease. That being said, it could have been much worse. There is a case report of a patient ending up in liver failure leading to liver transplantation, but this patient had pre-existing liver cirrhosis and portal hypertension. Serious liver injury can occur with no prior history of liver disease as well. There is a reported case of a patient developing transaminitis 9 months after initiation of Kaftrio, which progressed to liver necrosis, and despite stopping Kaftrio, and took many months to resolve. And so the take-home message would be to ensure that a multidisciplinary approach is used, including an experienced hepatologist, in cases where there is diagnostic uncertainty and in making decisions about commencing, stopping, or recommencing Kaftrio in patients with significant drug-induced liver injury. Thank you.
Thank you very much, Asbjørn. That was great. Lots of questions about use of CFTR modulators in post-lung transplant patients. So our next speaker, Kathy Ramos, I don't think you need very much introduction. You're well known across the CF and the transplant communities, but welcome. Thank you very much for agreeing to talk to us today. We've had a question in the chat. I see you've answered, but a question from Kavita Dave from Harefield about a real-life experience of using CFTR drugs in patients post-transplant who are also on medications such as the azoles and tacrolimus. So that question leads very nicely into your talk, Kathy.
Thank you. And is the view proper now, the presenter view? Okay, great. Thank you. So I just actually, you saw when I was sharing my screen, I added in a quick slide with some of our local data for PK with ETI, and hopefully I'll have time to show that to you. Thank you so much for the invitation to speak today. I'm happy to be talking about post-transplant indications for CFTR modulators and where are we now. I'll start out by telling you my disclosures. I received research grant funding from the NIH and the CF Foundation, but also previously had funding from Chest Foundation in partnership from Vertex Pharmaceuticals, but it was not related to CFTR modulators at all. And I've gotten honorarium and travel support from Vertex for talks that were related to CF epidemiology and transplant for CF. So I want to be transparent that Vertex has certainly supported my talks, but they definitely do not pay me to say anything about Trikafta after transplant. So the outline today, US data for post-transplant CFTR modulator use. I want to summarize what is known, give you some patient perspectives on elexacaftor, tezacaftor, ivacaftor, which I'll call ETI after lung transplant, just added in preliminary ETI PK data, and then sum up with the gaps and opportunities for the use of CFTR modulators after transplant. So just a quick piece of background, sinus disease, studies have shown that the sinuses act as a reservoir for bacterial pathogens in CF lung transplant recipients, and surgical treatment of sinus disease has been associated with a decreased risk of pulmonary infections. And there have been some conflicting results in small studies of sinus surgery for CF chronic rhinosinusitis and the effect on lung transplant outcomes. But it's important to recognize that the surgical techniques have evolved over time, and the newer, more aggressive endoscopic surgical techniques are thought to be more effective. And for patients in whom the sinus pathogens were eradicated, there was an improvement in 5-year survival and reduced rates of CLAD. So sinus disease can be very important for transplant outcomes. Also, CFTR modulator therapy, in this case ivacaftor, may enhance fluoroquinolone activity against Pseudomonas. And sinus disease before transplant is improved dramatically with ETI therapy, and there are several papers supporting that now. There are 3 small case series that have reported the use of CFTR modulators, either ETI or the dual combination of tezacaftor, ivacaftor, in lung transplant recipients at single centers in the US. I'm not going to go into too much detail. They've been mentioned earlier, but there are 3 of them, one with 5 patients, one with 7 patients, one with 9 patients. And the most common benefits were improvements in sinus symptoms, BMI, diabetes control, GI symptoms, reduction in pancreatic enzyme dose, and a reduction in antibiotic use and hospitalizations. Anecdotally, one person had improvement in their osteoporosis, a person had improvement in depression symptoms, and one other had reduction in liver transaminases. And the average dose reduction of Tacro was 20% in that one single report that had only 7 patients. So I want to share with you the ETI after lung transplant experience in the CF Lung Transplant Consortium, which is a network of 15 lung transplant programs in North America. And we conducted an electronic health record-based cohort study between October 2019 and September of 2020. And it included 95 CF lung transplant recipients who were prescribed ETI after lung transplant. And the inclusion criteria were really broad. They just needed to have a prescription, and some of the people didn't start taking the medications. 4 of the 15 sites had 0 patients who were prescribed ETI, and insurance denial was only present for 1 of the 95 people. So 94 out of 95 people had full insurance coverage for their ETI. 3 other people didn't start taking it for various reasons. And you can see here on the slide the conditions that were present and the conditions that were a factor in prescribing ETI for the people, the 95 people who were prescribed it. And sinus disease was the overwhelming majority of patients had sinus disease as a reason for the prescription. GI symptoms, low BMI, and the patient's preference to try ETI was also a factor. There definitely are challenges with start with the clinical outcomes. Some patients did experience clinical improvement, increase in their BMI for those with low BMI, an increase in hemoglobin for those with anemia, a decrease in hemoglobin A1C, reduced use of antibiotics, and reduced frequency of symptomatic acute cellular rejection. Those last 2, I recommend cautious interpretation because it overlapped the COVID-19 pandemic. And so there were limited in-person clinic visits and data collection and limited bronchoscopies being performed at that time. No sinus symptom or GI symptom metrics were measured in this cohort. It's just an electronic health records survey or data collection, but the physicians were asked whether or not the sinuses or GI symptoms improved, and several physicians reported improvements on behalf of their patients. There was an indication bias. Many of the patients were actually only the sickest or those with advanced disease with CLAD who were considering retransplant or had other comorbidities or issues that prompted starting a new medication. So there were challenges with ETI in the CF Lung Transplant Consortium. Immunosuppression management was only challenging for about 4 of the 91 patients who started ETI. And what I mean by that is they required more frequent blood draws to reach their target ranges for immunosuppression. But many patients required a small dose reduction of their tacro, but many had absolutely no change in their tacro dose. And so the effects of drug interactions on ETI levels is unclear because there was no clinical lab measurement for the components of ETI. And so that wasn't available during this time period. Of the 91 patients who started ETI, 39 or 43% stopped it. And of those 39, 7 people restarted it. So in the end, about a third of the patients remained off of ETI during the entire observation period. And the reasons for stopping are listed here: GI symptoms, not feeling a benefit. 3 people did stop ETI due to transaminitis, but when you looked at the population level in the LFTs, there was no significant population level change in AST or ALT. So I want to share with you some unpublished data. We recently received approval to examine ETI prescriptions after lung transplant in the US CF Foundation Patient Registry. And these preliminary data, courtesy of Dr. Nora Burtis, our UW Pulmonary and Critical Care Fellow, and also Liz Cromwell at the CF Foundation Patient Registry, they show that of the people who were transplanted in 2019 or earlier, and therefore transplanted before ETI was FDA approved in late October of 2019, approximately 40% of those patients have documentation of an ETI prescription date after their lung transplant date in the CFF Patient Registry. And for the more recent transplants, the proportion who are prescribed ETI after their transplant is likely lower because people who are ineligible for ETI based on their genotype are more likely to be transplanted recently. Not all CF lung transplant recipients appear in the CFF registry, so these data are entered by the CF program and not the transplant program. So the overall prescription rate may be lower than 40%, because people with CFTR modulator prescriptions are probably more engaged with the CF care team. And so we're actively working on analyses to compare the clinical characteristics of recipients who are or are not on ETI and to evaluate the clinical outcomes in this cohort. So potential indications for CFTR modulator use after lung transplant, I think sinus disease and sinus symptoms, low BMI or malnutrition, CF-related diabetes, GI symptoms, any of the above in combination with CLAD and consideration of retransplant. Those are important things that I think are more supported by the data that exists right now. Whether or not there's a role for GERD or osteoporosis or depression is not clear. Whether it could change the risk of malignancies for people with CF, I'm interested in that. CFTR is a tumor suppressor protein, and its dysfunction likely contributes to CF patients' increased risk of malignancies both before and after transplant. So I think that's an important thing to keep an eye on, but there's no data right now related to that. And the potential pitfalls for CFTR modulator use after transplant are listed here. Presumably, there's no effect on CFTR of CFTR modulators in donor lungs without CF. There are the drug-drug interactions, side effects of ETI that may lead to stopping and restarting of ETI, which could have implications for the immunosuppression management, and then cost relative to benefit. And so I want to shift and tell you some patient perspectives on ETI after lung transplant. We did a cross-sectional survey of lung transplant recipients with CF at the University of Washington between October 2022 and March of 2023. And all CF recipients were eligible regardless of whether they'd used ETI before or were eligible for ETI. And so we found 81 CF lung transplant recipients who were alive. We reached out to a majority, and 46 or 57% responded. And 90% of the respondents were aware of ETI from various sources. Oh, and only 11 of the respondents, which is about a quarter, had taken ETI either before or after their transplant. That's not there on the slide, but I wanted to comment on that. So what you can see from this slide is that CF lung transplant recipients self-report many non-pulmonary manifestations of their CF, and 100% of them had at least one CF comorbidity. And then what I'm showing you here are the perspectives on the use of ETI, and nearly all reported that it is at least somewhat or very important to treat their non-pulmonary symptoms of CF. And most would be comfortable taking ETI and are interested in learning more about the use of ETI after lung transplant. And they do have concerns about ETI use. The largest is related to how it might interact with their transplant medications, but also side effects, cost of the medication, whether their doctor recommends it, a lack of clinical trial data for people with lung transplant, and some others. So I just added this in, and I wanted to show you some early preliminary data of the pharmacokinetics of ETI while on tacrolimus without an antifungal azole medication. And so we did a prospective non-randomized observational study of the PK of ETI in CF lung transplant recipients who were concomitantly receiving tacrolimus and not taking other drugs with known interactions. And the participants were at steady state at the time of the study visit. And we assessed sweat chloride and collected 9 blood samples over the course of the day. And we compared the mean values for the 3 compounds in ETI to the confidence interval on the ETI drug label from Vertex Pharmaceuticals, and also to a group of non-transplanted individuals with CF for whom Dr. Gimbalot had measured their ETI levels in her lab. And so the levels shown here are measured in her lab. And what the main takeaway is that the overall concentrations of ETI appear similar in lung transplant recipients, and all participants maintained ETI concentrations above a threshold that's expected to elicit clinical benefit. And we did do sweat chloride tests on the participants, and for the people who had available sweat tests, pre-Trikafta and on Trikafta, the average decrease was 44 milliequivalents, which is a meaningful decrease in their sweat chloride. And so in conclusion, there are gaps in our understanding and there are research opportunities here. And I think we need a prospective study of the initiation of ETI after lung transplant to more fully evaluate clinical outcomes, immunologic effects, and lung transplant recipient specific side effects. And I think an RCT, a randomized controlled trial, would be the best option. So we could identify the populations most likely to benefit, studying the efficacy. And then we could also systematically assess for potential harms and safety. We could also leverage a prospective observational population who are initiating CFTR modulators clinically, but up to 40% of CF recipients may have already tried ETI. And then I think a study of continuation versus stopping ETI at the time of transplant is warranted, because right now I think there's a lot of heterogeneity in practice when somebody gets transplanted, whether they get taken off their ETI. Continue to evaluate the pharmacokinetics of ETI in the setting of transplant medications, and then expand the investigation of the patient's perspectives and understand providers' opinions about prescription of ETI, and explore the role of shared decision-making in ETI initiation after transplant. So further study is warranted to determine whether ETI can reduce the incidence of CLAD and improve outcomes for individuals with CF and lung transplant. But CFTR modulators may be indicated on a case-by-case basis in symptomatic individuals while we await definitive data. So I just want to say thank you to the ISHLT for the invitation to speak, the CFLTC for the data, CFF Registry, and then all the collaborators, mentees, and others who are moving the field forward. I will stop there. I see there's a chat.
Thank you, Kathy. That's great. Can I invite the panel to put your cameras back on? I've got quite a lot of questions, so perhaps if I kick off while other people are getting started. I'm going to start, Kathy, because with you. So very interested to hear that groups are using these medications for treatment of CLAD. We have a lot of patients who ask when they start to develop problems with their lungs, quite understandably, particularly the patients who've had friends who've got much better pre-transplant on modulators. What sort of rationale do you use for treating these patients when obviously they don't, as you also pointed out, have the CF defect in their new lung?
Yeah.
And anecdotally, what sort of results have you had?
Yeah, it's not for the CLAD itself. It's really for optimizing all the non-pulmonary aspects of their CF. A lot of times people, when they have CLAD, they also develop malnutrition and become very thin. And ETI in general really does lead to weight gain for people, CF. And so that plus controlling the sinuses better, potentially improving their diabetes control as well. So it's really the non-pulmonary factors when you're considering retransplant and trying to optimize them for that process. I will say that I've started people on ETI after transplant and they have diabetes on insulin, and there's been a lot of hypoglycemia. They need to cut back on their insulin. That is clear to me, and they need anticipatory guidance that if they're on insulin and start modulators, they need to call with hypoglycemia and reduce their insulin if their sugars are lower.
Okay, great. And then I had one more question actually about modulator therapy. I think this is really for anyone on the panel who wants to answer. It's about the immunological impact of modulator therapy. We've certainly, in patients post-transplant with CF and complex infection, started to have conversations with patients and with microbiologists, etc., about is there a potential benefit on immunological responses to infection, and could we help patients clear infection more efficiently if we were to give them modulators for that reason? And is there any data at all to support that?
I'll say that there's that evidence about enhanced fluoroquinolone activity for people on ivacaftor, so maybe there's that. But the negative side of improving the immune response is something that worries me in the back of my mind every time I start somebody on modulators is, are we going to fix their immune system and they're going to attack their lung allograft.
Yeah.
And, you know, all that CFLTC data showed a reduction in acute cellular rejection, but it was during a time where we weren't doing as many surveillance bronchoscopies because of the pandemic. And there are people who stop because of shortness of breath or cough, or a decrease in their FEV1. And so it's anecdotal. There's no systematic study that has been done of these medications to prove that they are safe.
Yeah.
And that worries me.
It worries me, yeah. I mean, we've certainly had a patient, again, anecdotal, one patient. We've got several patients on Kaftrio for different indications post-transplant, and we do need to, as a group, sort of collect all that data. But one in particular sticks in my mind, who we started Kaftrio for sinus-related disease. Lung function plummeted. We stopped it. It was over a weekend. Got better. Started again. Lung function went down. No evidence of acute cellular rejection on his transbronchial biopsy the second time, but we stopped it. His lung function got better. Definitely not going to start it again. You know, don't know what happened. Sorry, I'm going to move on a bit. Is there anybody who wants to ask any questions before I just carry on? Tom, I can see you've put your camera on, so I'm wondering if that means you want to ask a question.
No, I'm fine. I just wanted to point out that the CF registry is really inaccurate when it comes to the number of patients that have had lung transplants.
Yeah.
So, because one of the problems is that the patients that have been transplanted, many of them stop attending the CF center where they were, you know, being cared for, and they are getting cared for in the lung transplant, you know, clinic. Now, at our place, the lung transplant clinic links into the CF registry so that the data is followed, but that's not the case at many lung transplants.
Yeah.
It seems as though the people who were in the registry who get transplanted in the more recent era, that is more accurate because the CFF is starting to go back to each CF center and confirm transplant numbers and deaths without transplant in the more recent years. But post-transplant, the data is missing a lot more for the transplant.
Yeah, they should try and hook up with SRTR while there is still an SRTR.
Yeah, they just completed the linkage, actually, the CFF and SRTR, but it only goes through 2021 right now. So, but that's a great idea. Hopefully there remains an SRTR.
Well, I think the contract for UNOS is going to be changed, and perhaps the SRTR.
I was just going to add to that, based on registries. You were talking about US registry, obviously there. It is different across the globe in terms of what is instructed as to what is captured and what amount of data at the time of transplant. So, for instance, in the UK, again, it's not really captured. It's captured the transplant date, the time of assessment, but beyond that, actually, there is no instruction to, and there's no mechanism to actually. So I think there is a need internationally to do this better, definitely, because as you've seen from the pre-transplant registry data, it's a very powerful way of understanding evolution and important interventions that I don't think can really be answered from a possible.
I agree, totally agree.
Trial.
And the other point that I'd like to make is that the CF Foundation in the United States keeps patting themselves on the back about improved survival, particularly over the last decade or 15 years. And one of the main reasons for that improved survival is lung transplant. And they simply
and one of the most important studies has shown that, hasn't it, whereby the Canadian outcomes are much better, dare I say.
Okay, we've only got 1 minute left. I was very interested to hear Kathy and Nick and anybody's views on, we're in this new world now. We do have a cohort of patients with very established structural lung disease who have got massively better. With all of our patients, 90% of our patients have got better and no longer need transplant. Where's that going? Are they coming back to us?
I think it's a really interesting time. I really do. I mean, we were discussing some of this. I think, there's been the honeymoon period, as people like to call it, the uplift, and there are patients who have low lung function, who are exacerbating, who are definitely deteriorating, who definitely will require transplants. The timing of which is really, really challenging, because the circumstances and the sort of how the disease is behaving and everything around that is different, But without doubt, large cohort of mostly adults with established disease who still have, disease that is at risk of deterioration and transplant. Haven't quite got a sense yet of the frequency or exactly what that's going to look like, but certainly, as you know, in London, we're beginning to see it. Small numbers, but we're definitely beginning to see it, aren't we?
And they can be very, very fragile, go from very good lung function to very sick very, very quickly, which is something I think new and is a novel thing in the context of these modulators. Okay, I think we've reached the time cutoff for the session today. So thank you very much to everybody who's joined us. I hope all the attendees have found it interesting. Juliet, I believe this session, this webinar will go on to YouTube if you want to share it for anybody in your team. Educationally, it's open to everybody, ISHLT member or not. I think that's it for today, but good to see you all and hopefully see some of you in Prague in April for the annual meeting. Bye-bye.